So good afternoon, everybody. And thanks for holding up your energy for this next session as we think about how we can better engage with patients in our research endeavors. The focus of this short discussion is around how does the SPOR support unit, the Strategies for Patient-Oriented Research, connect to issues of women's health research in the province of BC. SPOR is a relatively new entity in our system, and we're still trying to figure out how it connects and how we can best utilize it. But one of the things that SPOR has taken a real championship approach to is to building on the role of patients in research. It's a big issue of the day, and it's a very important one for us as a community to get right so that people feel engaged and participatory in the research endeavors. And with that in mind, it's very unfortunate that Colleen McGavin, who is scheduled to be on the podium today, is not able to be with us, who is representing the patient voice in the perspective. So I've tweeted a little bit, Matt, on this, and I would encourage us in the room to make sure that you bring forward some questions along the way here to make sure that we are giving voice to the importance of patients in the research process. My name is Wyeth Wasserman. For those of you who don't know me, I'm head of research at BC Children's Hospital and the Associate Dean for Research for UBC out on the Oak Street campus. And one of the great joys in my job is getting to work with Lori Brotto and the team in the Women's Health Research Institute and promote the cause of women's health research. So I'm thrilled that I was invited to participate today, and I'm excited to be up here on the stage giving a chance to bring voice to this. I'm joined up here today by two members of the SPOR team. On the far left is Stirling Bryan. So Stirling Bryan is a professor in the School for Population and Public Health here at UBC. He's an economist, so he brings a health economics perspective to what we do in our research endeavors. He's based in C2E2, the Center for Clinical Epidemiology and Evaluation, and in that role, he's been working with a wide variety of partners across our system. And so he's one of the better connected people in BC in terms of understanding where health research comes together. And it's one of the reasons that he was selected to be the inaugural scientific director for the SPOR support unit for BC. And in that role, he's charged with building those relationships and connections across the system. Cheryl Armstrong, who is sitting next to Stirling, is a research navigator within the SPOR program. So she's based on Vancouver Island and is championing the interests of the program projects within the system. She serves on the Vancouver Island Regional Center's Operations Oversight Committee, and on the operations team as a research navigator for the South Island. She's, I won't say how many years because you're too young to have those numbers that I see here in the system, but she's has diverse healthcare experience, including critical care trauma nursing, cardiovascular perfusion, health research, and research project management. And she's passionate about improving health outcomes and enhancing patients' health-related quality of life. And she holds a Bachelor's of Science degree in nursing, a certificate in cardiovascular perfusion, and a Master's of Public Health. And so brings that intersection of applied clinical experience and an emphasis on research activities. So what I've structured to do here is to start the day to give a couple seed questions to the team here, and then I'm going to be looking to the audience to engage and provide a few questions as we go along. So, Stirling and Cheryl, I would like to start with maybe a small softball question as we go in here. Can you give me an example of where patient-partnered research has been successful? It can be within BC or anywhere outside the system, but exemplars of where the patients have been built into the system from the beginning and allowed the research to do more than it would otherwise have done.
Do you want me to go first?
Yeah.
So I'm also the Health Research Project Officer at the University of Victoria, and we have a strong history there of community and university-led engagement. And a couple of our researchers, Cecilia Benoit, who does research with around sex workers and looking at the ramifications of the bill that was mentioned earlier that needs to be repealed. She engages the patients, which very broadly speaking is people with lived experience. So that could be the fact that you have unstable housing, that you are a sex worker, that you are a cancer survivor, that you've just had cardiac surgery. But broadly speaking, it's patients. And so she has engaged people with that lived experience in her research and help them inform the research and identify priorities that really matter to them and looking at outcomes that are meaningful for that population. We also have researchers such as Bernie Pauly, who works with, engages people with lived experience around mental health and substance use, and works with community partners on the island, such as Solid and Umbrella, and has really shaped research around meaningful outcomes that population will resonate with them.
Great, and I'd just like to say thank you very much for the invitation to speak at the meeting, and I see so many faces that I recognize in the audience, and it's a pleasure to be at an event where women's health is given center stage. So I would say, I mean, apologies for those who've heard me talk about knee replacement surgery before, but I just like always default to this story and top marks to Fraser Health and Susan Chunick and her team who sort of got this work going. But one of my sort of early experiences when I landed in BC in it was about 2009, was an orthopedic surgeon walked into my office and said he's got a question for me, and his question was why so many of his knee replacement patients were so unhappy. And he was intrigued by why he couldn't seem to, he thought he wasn't sure whether he was not doing his job well, whether he just got patients who just were grumpy patients or what was going on. So together we started looking at this question of, is this a common problem or is this just an exception? And it became clear that this was actually a common problem. Something like 1 in 5 patients who have knee replacement surgery end up indicating some level of dissatisfaction. So that started me down a path that then said, well, actually, we need to be listening to people when they say they're not happy. Why don't we routinely listen to people in the healthcare system when they say they're not happy? In fact, we don't even ask them whether they're happy or not on the whole. So it took us down a path to try and understand what some of the issues might be, and we've done a great piece of work, I think. So I don't want to. It's the team who I work with who've done the great work, and to try and sort of understand what some of those issues really are, doing it in a mixed methods way. So we engage patients as partners in that research enterprise, as well as having patients obviously as subjects. We have done qualitative work as well as survey work. So I think it's not just about finding things that don't work, it's about trying to find things that do work and learn from that. But if we don't listen to patient voices and patients' voices, recognizing the heterogeneity of patients' voices, then I think we have a real sort of philosophical problem, and I think we're moving in this direction. And it seems from the discussion that was happening this morning, which sadly I wasn't here to hear, but I have followed on Twitter, so I am at least trying to be aware of what's happening through the
Keep
conversation.
tweeting, everyone.
Yeah, absolutely. And then I understand that there was quite a lot of conversation about how to truly engage patients in women's health research this morning, which is obviously where we want to go.
So SPOR is, as a Strategies for Patient-Oriented Research endeavor, is aligned with the times, right? We are supposed to be achieving this future state where patients are true partners in the research. And more often than not, I'm seeing that it's lip service right now, that is not yet patients as true partners in the process. And that's largely because I think the researchers have not yet figured out what it means and how you achieve that level of connection. And so as SPOR is stepping forward in the activities, what are you doing to promote more robust patient partnerships in research programs?
I'll go first. So on the island, we have a couple of key populations that we are engaging. Although the Indigenous population only accounts for 10% of the population on the island, they account for about a quarter of the Indigenous population registered with BC First Nations. We also, what we have is we call the Grey Tsunami, that we are leading the country in having one of the oldest postal codes in the island. And we have 10% of our population that's over 75, and by the coming decades, that's expected to more than double. And Victoria, along with Vancouver and Surrey, has the unfortunate distinction of having one of the highest illicit drug overdose rates in the province and in the country. And so we feel that we have a leadership role that we can play with each one of those populations. And what we plan to do over the coming months and years is convening these groups of patients around priority settings, and it could be through various mechanisms. With the Indigenous population, it would be engaging elders and the communities and acknowledging the Indigenous ways of knowing and how they would like questions and priorities addressed that is meaningful for those communities. and also convening with seniors and listening to what their priorities are versus making the assumption, as researchers have over the decades, of what we think is important.
Sterling, is there broader structural pieces across BC that SPOR is promoting?
I think, like this is, in some ways, this is like trying to change the culture, which is easy to do in theory and very challenging, obviously, to do in practice, unless it's obviously in a test tube where the culture is easier to manipulate, I guess. But that's not what we're talking about, sorry. So I think like the changing the agenda so that we actually start thinking about research on topics that matter to people who live with the health condition in question, I think is a very exciting challenge, but a very difficult challenge because, I'm part of the research community, we're all part of the research community, and we have a sense that we know what's best in terms of what should be researched. We make those arguments we think in a compelling way when we submit our grants to CIHR, and then we get knocked back because they don't get funded, but we still believe that we've got the right questions. And I think we have to start saying to ourselves, actually, no, we aren't the people who should be addressing those determining what the questions are. We should actually be going out and effectively engaging with people who live their lives struggling with chronic disease or whatever the condition is in question, and actually listen effectively to those folks to help us try and set the agenda. And that's certainly part of the work that the BC Support Unit is wanting to take forward. And we've put in place mechanisms whereby we can try and do that. So we have a distributed model. So we have offices that are now up and running in all of our regional centres, in all of our regions across BC. So we have regional centres, and we have people who are experts in and leaders for patient engagement in all of those regional centres. So I think if you're interested in this field and want to bring a stronger patient orientation to the research you do, then come and talk to us and engage with the BC Support Unit. You can do that through the website. There's a simple form you can complete, and that'll put you in we'll connect you with the right people locally who can help you take that forward. Just as an example, I think one of the things that we're doing within the support unit is creating a patient council. So actually every sort of aspect of the work we do, in a significant way, we get consultation with a patient panel to guide us, even on appointments. So all of our appointments have a patient as a member of the appointments panel. So we're trying to be real about this and do this in a fully engaged way, because I think it is important that we're not just telling people how to do it, we're actually doing it ourselves within the support unit, or at least that's what we're trying to do.
If I could just add to that, I can't speak to the other centres, but on the Vancouver Island Centre, we have a patient partner who helped us write our business plan that we submitted to the BC Support Unit, and he's been with us a year now, and his voice is really important, and he brings a lot of insight, and he's again with us going into our second year, helping to inform our deliverables, and we're embedding them on our governance structure. And when we had new hires for our regional center tasked with doing this work, we had 2 patient partners part of our hiring committee, and their insight was really, really incredibly helpful.
So we've touched on it a little bit, but as we think about a province-wide approach to research and care, can you give me some examples besides the island? Welcome to give me another one on the island, but some examples where we're reaching out across BC and some of these navigators are coming into play to help promote the projects that reach in the corners. I know it's early days.
There you go.
Okay. It is early days, and we have actually representatives from other regional centres with us, so I would encourage those folks to speak to this as well. So, we are a distributed model, as I've indicated. Just so that you're aware, the governance for the BC Support Unit in its entirety comes from the Academic Health Science Network. which is a province-wide initiative or network that's now become a reality. So that sort of gives us the frame that's already a provincial frame, because the board that we report to is always asking us not just about what we're doing in the Lower Mainland, but across the whole province, and wants this to be a truly province-wide initiative. There are two sort of pieces. I mean, I always talk about a reactive and a proactive sort of work streams for the units. The reactive is you've got a question or you've got a project and you want to engage with us, then come to us and we'll try and support that. But also then the proactive is actually to say, what are the provincial priorities? So what are the priorities at a provincial level that we want to take forward? And we need to have an engagement with all of our relevant stakeholder groups to determine what those might be. But the plans are for us to have province-wide initiatives that we can move forward. And I think we often sort of view BC as being a really challenging place because of its geography. But actually I think we should embrace, like, what is it that we can really do in an effective way because we live in British Columbia, rather than why is it that research is such a challenge because we live in British Columbia? And the rural and the remote, delivery of effective and high quality, cost-effective healthcare to rural and remote communities, I think is certainly on the agenda. And I think, partly because we're listening to people across the province rather than just in the Lower Mainland.
So I think in the audience, one of the things you should have picked up on that statement was the role of advocacy for bringing attention to the research issues that matter to us. And from a women's health research perspective, one of the things just to make sure is that the SPOR team is engaged and you are bringing forward the key issues that are timely and ready to move on. I'd like to give a chance for the room, so if there are any questions in the room or statements, we have, I think, a microphone somewhere, and be happy to take on a question. So I see a hand pointing over there. Thank you. Okay.
Hi. Thanks. Yeah. I was wondering, so a problem that I see with community-based research and the execution of it, I really appreciate Dr. Wasserman's point about, at this point, perhaps it hasn't been implemented as robustly as we might hope. And I think one of the risks that can occur is if you are starting to engage in community-based research, but are not adequately funded or supported to do so to really truly honor the patients as partners, then there's still that power imbalance and dynamic, and you could be actually taking advantage of them in a vulnerable position. And part of that is about the sustainability piece, because it's important, I agree, that patient voices are heard up front and are defining the agenda, but it's really important that they hear about how the research went and that they continue to be involved over the life course of the project. And our current funding model is very project-based and in 1 to 5 year kind of cycles. And at the moment, the way I see it is that there just isn't the funding that actually is in line with what community-based research really requires. So how do you reconcile, or what do you propose as a way to actually make community-based research happen in a way that truly honors the patients as partners?
One of the things that we recommend, and for our first team that we had, it was around people with lived experience of mental health and substance use, and looking at creating a culture of safety and reducing the stigmatization in primary care. And we had from Umbrella and Solid, which are two peer mentoring groups with mental health and substance use, we had 6 patient partners while we were developing the priorities and then fleshing out the grant and what we wanted to look at. And one of the ways that I agree with you that the funding mechanisms are not ideally suited right now, but one of the ways that the regional centers have been structured is to provide in-kind contributions around, so for example, and all the regional centers are pretty much set up the same. So there's a research navigator, there's a patient research liaison, and there's a knowledge broker. And those are in-kind supports that the researchers can add to their grants, that we can provide, services that can help support the research teams both pre, post, through to integrated KT. Does that answer your question?
Sort of. So this is a model for having a salaried person to sort of play a bit of that role and have some continuity there. Is that what you're saying?
Well, we're tasked with supporting all of the teams, and that support will look different depending on the team. If they've worked together for quite a long time and they have strong relationships and those patient partners are comfortable with the research process, clearly those teams will require less support from us. But for the teams that are new and haven't got those relationships or the trust built, then obviously we'd be supporting those teams in a more fulsome manner.
So if we expect the research teams to automatically have that patient partnership at the front end, and they don't have the expertise to build those relationships, it's not going to take off. And so as organizations, we have to make sure that those relationships are enabled and supported. And that means that we have both the front end piece and the back end piece. Now, for many of us who are in the research space, we know when we're writing a proposal, we're always required to write a lay summary to sort of describe what we're doing in real terms, usually badly. I've never seen a closing report on a project that's expected to present things in a lay term. And so there's partly an accountability framework around how we complete our projects to make sure that we bring that closure to projects successfully. And that means it goes beyond necessarily the 5-year cycle, because you're obliged to complete and report on your projects even beyond the funding period. Dr. Ogilvie.
Thank you. Thank you for this presentation. I wanted you to speak a bit about, so one of the, I think it's tremendous to have the patient-oriented research approach. One of the challenges, though, is I think we can sort of further create inequality, because the folks who feel comfortable coming forward advising on research questions often are highly educated, very engaged. And so one of my concerns is that particularly for women who have limited resources, huge childcare tasks in front of them, working, and then also adolescents, I really concerned about that they actually simply are not able, don't have the agency to actually engage in this. So could you talk about how you're going to work with those groups to make sure that their voice can come forward?
This is when it would be good to have Colleen here.
Do you want me to start?
Sure.
So I think this is a critical point. So thank you very much, Gina, for raising it. And I mean, the reason that I got interested in economics was because of an equity lens that economics can and should bring. Sometimes doesn't, but should. So like my line on this one has always been like, if what we end up doing through the support unit is making health research, healthcare, and access to care better for the educated middle classes, then I'm going to shoot myself, because I'll have completely failed in the job. And I think I think there's a big danger that that's what we're going to do. And so I think we need to be continually vigilant that we're not falling into that trap, because it's the easy place to be. So I think Patient Voices Network has been a great development within a British Columbian context, but they recognise that the diversity available of patients' voices through the Patient Voices Network is very limited at this point. They're working hard to change that, but it means that we can't rely only upon an organization like Patient Voices Network in order to bring folks in. So we've got to work really hard, and I'm not saying we have all of the answers, but we know that this is a big danger, and I think it's a real danger, and I would use that language, that we can fail and fail badly, and actually make inequities greater as a result. So I think we've got to be very, very careful on this file, and I would want to bring everyone who's interested in that particular issue to help us and support us to make sure we do that well. And honestly, I mean, a shout out to Wendy Norman, because the agenda that Wendy's opened my eyes to so many things, almost all of them like very educational and good, but that equity issue around access to highly effective contraception and that agenda is just so important from an equity lens. And I think that's exactly the sort of work we need to try and take forward, and use that as an example of how do we effectively engage marginalized and disadvantaged groups in order to really sort of give voice to those folks. So it's a very important question. Thank you.
Yeah, and I would say it's not just the people that are hard to reach for the obvious reasons, but with an elderly population, and it's one of the Ministry of Health priorities, family caregivers are a very challenging group to engage, because, as someone mentioned earlier, the sandwich generation, I think is what they're talking about. They're caring for elderly parents. They're also doing child rearing, and they're carrying a huge burden. And of the 8 million informal caregivers in Canada, a good chunk of them are women, and they're trying to balance both. And we need them engaged in research, and I think it will be a challenge to bring them to the table.
So we have time for one last question, which is going to go to Dr. Pryor over here on the side.
So my question is, do you have a commitment that whatever research comes out, whatever results come out of your research are shared with the participants in the research, whether or not they've yet been peer-reviewed?
Well, each of the regional centers, I'm not sure if I'm answering your question, so tell me if I haven't. Each of the regional centers has a knowledge broker, and they will embed on research teams, and they will ensure that the KT activities are patient-focused and accessible to the target audiences. Is that what you're...
No, presumably, once it gets going, SPOR is going to do research, right? And when you do research and you engage, I would much prefer people or public or women rather than patient, because that has a power imbalance connotation to me. All of us have lived experiences, whether we're in a hospital or taking drugs or have a disease or not. But when we do research with people, we have an obligation as researchers, I believe, to share the results of each person's commitment to that research with those who did it. And so I think this is a transformation that hasn't happened yet and that must happen. And if SPOR isn't leading the way, then shame on you.
Well, let me say why you shouldn't be thinking that there should be shame heaped upon us. If I can sort of give, so SPOR isn't doing, so the support unit is not conducting research. It's there to support the activities of the research community. So I think there's leadership by. I mean, for me, it's like good science is actually, and respectful science is about recognizing the time and commitment that people make to ensuring successful research. That includes patient subjects. That includes patient partners. So your question was whether we had a commitment to sharing the research findings with research subjects before peer review. Now, I'm not sure that I'm going to make that commitment. I certainly think that sharing research findings or encouraging teams to share research findings with research partners who are patients is absolutely what we should be doing. We should be looking at the data with patient partners. We should be then ensuring that we have robust results before we share those results with the world and even with the patients who were party to the research or participants in the research, because we don't want to mislead people. So we want to make sure that we have robust research results before we share those with the patients who were the subjects. But that will come through a partnership with patients as team members in the research if we take this initiative forward. And on your issue about patients as a label, I think it's not a great label. It's what we're stuck with because CIHR has the strategy for patient-oriented research, so we have to use that that language, but we always say that we're just using the word patients really as just a shorthand, and we actually believe that, in fact, we should be talking about people rather than patients. I fully support that position.
So it sounds like good fodder for the coffee break that we are about to enter into. Dr. Brotto is at the microphone ready to transition us into it. Just as my last word here, one of the things I'll take away from this is that the doors are open at SPOR for us to engage and encourage and catalyze work on the women's health, and so have at 'em.
And since we've been sitting all day, this might inspire you to walk out the door and sign up for the May 13th Shoppers Love You Run. You have the option of a 5K walk or run or a 10K run. I would love to have 150 folks run beside me and many others in the community. And so we are now going to take a 15-minute coffee break.